Hello, I'm Nitin Jain from the Department of Leukemia at MD Anderson Cancer Center in Houston, and accompanied today by my colleague here, Dr. Bill Wierda, who I will ask to introduce himself.
Hi, I'm Bill Wierda from MD Anderson. I work in the leukemia department and in the CLL program.
Great. So at the ASH meeting, Dr. Wierda presented a very important abstract where they used Acalabrutinib, which is a BTK inhibitor with Venetoclax for all patients, but some patients got Obinutuzumab right away, like a triplet regimen, and there were some patients who got it later. And so it was a randomized cohort, randomized trial. Some patients got doublet versus triplet. And those results for the newly diagnosed patients who meet IWCLL treatment criteria. So basically their disease has progressed. They needed their first line treatment, were enrolled at MD Anderson Cancer Center, and Dr. Wierda presented those results. So Dr. Wierda, you want to comment what you exactly did, the trial design, and what the results were for the patients here?
Sure. So the trial that you're referring to is a randomized phase 2 clinical trial, meaning that we're looking at MRD rates and comparing two different treatments. One is Acalabrutinib plus Venetoclax. The other is a triplet of Acalabrutinib plus Venetoclax plus early Obinutuzumab. And the concept is to determine which combination is more effective if you're looking at the MRD rates at an early time point, after 6 months of combination therapy and after a 1-year time point of combination therapy. And as you said, this is a frontline cohort, so all these patients were previously treated. Half of them received the triplet, half of them received the doublet. And the idea was to show that there was an improvement in the MRD rate, undetectable MRD rate, in patients who got the triplet over the doublet. And that's basically what we saw. There was a significantly higher undetectable MRD rate for patients who received the triplet compared to the doublet. Now, those patients who didn't or did, those patients who were still MRD detectable at the end of a year could get 6 months of Obinutuzumab therapy, whether or not they got it in the very beginning of the treatment. And the idea behind that was to see if we could improve the response rates beyond what was seen at the 1-year time point. And in fact, we were able to show that there was, for those patients who didn't achieve an undetectable MRD status, most of them could if they got the later Obinutuzumab. So by the end of the trial, there was a significantly high proportion of patients who were MRD undetectable, whether or not they got the early Obinutuzumab. And I would say that most of the patients on that study ended up getting the triplet at some point, whether it was early or midway through the treatment trial. And I think this data is complementary to the Amplify trial that was presented at ASH. The Amplify trial, as you know, is a 3-arm randomized clinical trial of Acalabrutinib-Venetoclax, Acalabrutinib-Venetoclax Obinutuzumab versus chemotherapy, showing that improved outcomes were associated with the Acalabrutinib-Venetoclax or Acalabrutinib-Venetoclax Obinutuzumab treated patients.
Yeah, no, that's a great summary, and maybe we'll take your thoughts. So you mentioned about the Amplify study, and so this data and the Amplify study are very complementary in that sense, as you mentioned. So with the kind of the upcoming approval, which we expect that Acalabrutinib plus Venetoclax, maybe with and without Obinutuzumab, will get FDA approved for patients with CLL based on the Amplify study. Do you think for majority of the patients, I think, will that be kind of the regimen in the time-limited setting to kind of move to compared to patients who are getting Venetoclax plus Obinutuzumab? Because a lot of patients may be thinking, can I get an all-oral therapy for their next line of treatment, given the results from the Amplify study and with your own study?
Right. So one of the things, as you know, that we think and talk a lot about is what's the optimal duration of treatment with combination targeted therapy. And I can provide perspective, and you can provide perspective on that in terms of Ibrutinib plus Venetoclax, which is a very effective combination therapy, which was never approved in the US for first-line treatment for patients, but certainly is very effective and was approved in Europe. And it wasn't approved because of the toxicity profile and the side effects that we worry about associated with ibrutinib. Now, with acalabrutinib, we've seen that it's safe to combine with venetoclax, and that there is a high undetectable MRD rate. With the Amplify trial, it was a fixed duration treatment, so all patients received a year of treatment. Whether it was the doublet of acalabrutinib-venetoclax or the triplet acalabrutinib-venetoclax. On our trial, the one that I was just mentioning, everybody got 2 years of combined therapy. My opinion is that if you really want to optimize your outcomes, that you have to work towards getting patients MRD undetectable. We saw an improvement in the undetectable MRD rate in patients who were still detectable with the doublet at the end of a year if we gave them a second year plus a CD20 antibody. And I think what we'll learn with the MAGIC trial, which is acalabrutinib-venetoclax versus venetoclax or obinutuzumab, where if patients are still MRD positive at the end of 1 year, they get a second year of acalabrutinib plus venetoclax. I think with that trial, we'll learn that most patients will end up getting 2 years of treatment. So my overall response to your question is that I do think acalabrutinib-venetoclax is an important combination. It's an all-oral combination. It avoids using the CD20 antibody, which can be immunosuppressive. But if you really want to optimize your patient's outcomes, you may have to give 2 years of treatment rather than just 1 year of treatment.
All right. No, I think wonderful thoughts. So thanks a lot, Dr. Wierda, for coming on and your thoughts about the trial. Thank you.
Thank you.